then someone quietly, remember we had a birth companion, follows you as the provider who just delivered our bouncing little baby and tells you, daktari, ama nurse, ama sister, mgonjwa bado anamwaga damu. Within seconds, the atmosphere changes within you and within the labor ward. You reach out for oxytocin as somebody else is calling the doctor or the consultant, somebody else is picking IV fluids, the laboratory is being called, the theater team has been put on standby, and someone is asking, kuna damu, kuna damu. The ambulance driver is also warming up the engine just in case, either to pick blood or to refer the patient. And suddenly, what started as one woman's delivery becomes everyone's responsibility. Do you feel that? Are you imagining that? So if you've worked in maternity, you've probably lived that story. Some of us have celebrated because she walked home with her baby. Others still remember the patients we couldn't save. Tonight is about those women. It's about ensuring that no matter where postpartum bleeding begins, a dispensary, a health center, a county hospital, a referral facility, every member of the healthcare team knows exactly what to do, when to do it, and how to work together to give that mother the best possible chance. And remember the baby as well. Karibuni sana. So without further ado, it is my great pleasure to invite Dr. Lois Nyanjao. She serves as the head of maternal health program in our Ministry of Health, that is Kenya, in case we have some of us joining in from outside of the Kenyan borders. She provides national leadership in advancing maternal and newborn health. She has played a very vital role in strengthening quality maternal health care and improving national strategies aimed at reducing preventable maternal deaths across Kenya. Dr. Nyanjao, we want to thank you very, very much for your continued leadership and commitment to improving maternal health in our country. Kindly, Daktari, set the stage for us and officially welcome us into today's discussion. Karibu sana.
Thank you so much, Dr. Beverly. Good evening, good morning, good afternoon, wherever you may be. I'm so glad to be here again and to have all of you colleagues join us in this webinar. We have such an amazing panel of facilitators who will walk with us the journey of identifying and managing our client with PPH. And I'm so glad that you're here. Please remind your colleagues to join us. We want to start together, and my colleagues here from various counties, facilities, and we even have a professor this time in the panel. I'm sure we will really engage and share knowledge. We were happy to learn from you, and I'm sure you will learn something from us. So karibuni sana, call your colleagues to come in, and we get started together. Back to you, Dr. Mitei.
Thank you very much, Dr. Nyanjao. It's nice to put the face to the name for those who do not know her. We are so happy to be here. Thank you for doing this for us. As healthcare workers, these sessions are very important. So before we begin the scientific sessions, I would like to invite Nelson from Kenyatta National Hospital. And on behalf of everyone joining us this evening, please pass our regards and messages of appreciation to Kenyatta National Hospital for continually providing this platform that allows healthcare workers across the country to learn, interact, and share experiences. Nelson, kindly brief us on the availability of today's presentation, the process of obtaining CPD points for different cadres, and of course, the part that I hope everyone is eagerly looking forward to, as initially hinted during today's reminder, the MCQs. Karibu sana, Nelson.
All right, asante sana, Dr. Mitei. Karibuni sana to all of our participants. Welcome to this session. This is the third installment of the series we've been running on obstetric emergencies. So kindly note that the chat section will remain open for you. You can interact with the panel. You can also interact with the rest of your colleagues, or rather the participants on this call. Kindly feel free to let us know where you're joining us from. For any question that you might have, kindly channel it through our Q&A section. Remember, these controls can be found at the bottom of your screen. If you're using your phone or a tablet and you can't see these controls, kindly swipe to the left or right, and you will be able to see the controls. Also note that this session is being recorded and it will be uploaded to our YouTube page, that is at KNH Research on YouTube, or you can always search for KNH UN webinars and you will be able to find our channel. The two past previous sessions have been uploaded together with the resources. This includes the webinar slide, the presentations that were there, and also the tools that can assist you in your everyday ongoings at your workplace. So lastly, I would like to notify you that your CPD attendance for this session will be tracked and you will be awarded your CPD points as per the guidelines you can always find on our registration pages, and you can also find them in your reminder emails, that the ones that we normally send for these sessions. If you do have a query or would you like to follow up on your CPD points, kindly feel free to reply to the email that sent you the notification. Kindly make sure to just let us know your name and also the cadre you're following up, or you can also let us know your regulatory body, and our teams will be able to assist you. And with that, I would like to hand it over back to Dr. Mitei to continue the session. Asanteni.
Thank you very much. As you're continuing to tackle those MCQs, do not feel there is no right or wrong answer, and most of the answers, if you're not sure of, will probably be answered by today's presentation. So thank you so much, Nelson, for reassuring us of the videos going to be uploaded and the presentations, and for us to, of course, get the CPD points. I hope you've picked a cup of tea or cold water if you live at the coast like me, because today, I promise you, you'll be glued to your seats and you'll be learning quite a lot. So now, allow me to invite someone very, very not very new to your ears, but very important in this conversation of PPH. It doesn't really need an introduction. But I take this as an honor to introduce Professor Moses Obimbo. He's a professor of obstetrics and gynecology at the University of Nairobi, also a consultant obstetrician gynecologist at KNH, honorary secretary of COGS, and a respected researcher whose work continues to shape maternal healthcare in Kenya and beyond. He's a mover. He's made the world have the first PPH walk, run, cycle, whatever you need to do on that day, just do it for PPH awareness. And he started that journey and championed that journey. As we begin today's journey through postpartum management, Professor, kindly share your words of wisdom, and help us understand what you see as the next frontier in reducing maternal deaths due to postpartum hemorrhage. Karibu sana, and thank you for your contributions in research, policy, and clinical practice. They have greatly influenced maternal health care in our country. Karibu, Prof.
Thank you very much, my colleague, Dr. Mitei. And thank you, everybody, for having given me an opportunity to share with you about management of postpartum hemorrhage, and specifically looking at the health system approach from a dispensary level to national referral levels, and with a specific emphasis also on implementation of the emotive bundle. I know we're talking to diverse group of stakeholders and populations, so I try my best to make this presentation as straightforward as possible, practical, applicable, and hopefully you'll find this useful to all of us. Feel free to give in more information. And I just say a little bit about what we do. So I'm the lead NPPH initiative, which came about as a response to the WHO call in 2023 that they realized that PPH is a big problem, and mostly a big problem in this part of the world, in sub-Saharan Africa. And so they came up with a 2023-2030 strategic roadmap to be able to address postpartum hemorrhage. In the process, they gathered that there weren't any particular groups or efforts that were able to push this agenda forward, but also aggregate funding to ensure that PPH is vanquished. It's for that reason that we came up with this initiative, the End PPH initiative, that has 4 strategic pillars. And in answer or in response to the WHO strategic roadmap. And these pillars were advocacy and community engagement, noting that postpartum hemorrhage as one of the biggest threats in our population is just not a medical issue. It's also a community's wound, because every time a mother or a woman dies because of postpartum hemorrhage, a community is left with a wound that they cannot be able to heal. A husband loses the wife, the children lose the mother, the people lose their sisters, and so forth. So we needed to engage the communities in advocacy to make sure that there is enough investment, and there is, of course, learning points, cross-cutting from other sectors of the community that can be able to help us in managing postpartum hemorrhage. In that course, we also advocated for establishment of the World PPH Day, and we're very happy that in 2025, through President of FIGO then, Professor Kihara, and the other team members from ICM, the WHO, 5th of October was then gazetted as World PPH Day to remember the families, the women, and the people who've lost their loved ones or that suffered in the hands of postpartum hemorrhage. And of course, now we also recently said we need to have this, day commemorated all over the world, and of course have a run every year, just a week before the World PPH Day. So every end of September, the last Sunday of September, we have a run, and the run started here in Kenya with about 1,200 participants in the first year. And since then, the second year, we had over 20,000 people participating. And we're hoping this year we have over 50,000 participating in over 20 African countries and other parts of the world. So that's advocacy, community engagement. Make sure that we have enough, information, and people get to know that they need to participate in the management of PPH, not just as a medical issue. The second one was research and reskilling, and we generate evidence locally that's able to solve our own problems, including local innovations. It's for that reason that we recently had the first ever World PPH conference dedicated to PPH, and we also had hackathon attracting very young participants, able to give solutions that can be able to address the issue of postpartum hemorrhage and other obstetric emergencies. Over 160 participants from all over Africa and other parts of the world participated. And these discussions definitely bringing forth the importance of postpartum hemorrhage and other obstetric emergencies. Health system strengthening is key, and that's what we'll be looking at in this particular approach. And finally, we definitely need to strengthen our data ecosystem, because with bogus data, you make wrong decisions. So we always need the right data to be able to make the right decisions for us. Then in addition to that, we also have an initiative on strengthening blood and the blood products, not just as a maternal issue, but a general health system issue. And we're hoping that we increase the number of blood donors from what we currently are able to achieve every year, 320,000 donors, to 1 million donors that are repeat donors, so that when a woman goes to the hospital, we're not looking for blood, but the woman, whenever she needs blood in the hospital, she will be able to find the blood. So we have the concept of the roaming blood donation program, and we're hoping to also strengthen the blood ecosystem to ensure that no woman dies because there was no blood. So that's what some of the initiatives we've been able to do under the NPPH initiative, and of course, strengthening what we are able to do as a country at large through the Awareness Acceleration Program and the Rapid Results Initiative. I'm very much always inspired by this great leader who knows and says that countries and ultimately the world are only as strong as the health of the women, and therefore worthwhile investing in the health of our population and our women. A woman's health, pre-pregnancy, during pregnancy, determines not just the generation that comes immediately after, but this determines the health of the generations up to the fourth level. So that's why it's imperative that we need to be able to invest as much as possible in the health of the women. And we know the pregnancy health will start long way before the woman gets pregnant. And that's why we really need to invest in the upstream health of our women. This is what we probably not want to hear, that we lose 260,000 mothers because of pregnancy-related complications. Last year, this happened. You cannot imagine this staggering figure. It's a number that you don't want to imagine. And out of this, 70% of this death were in sub-Saharan Africa. meaning that about 182,000 women in sub-Saharan Africa died because of pregnancy-related complications. About 70,000 women died because of postpartum hemorrhage. 56,000 of these women were in sub-Saharan Africa. That's a big number. And this number died because of the postpartum hemorrhage. In Kenya, specifically, looking at our maternal mortality rate of about 355 per 100,000 live births, it means about 2,000 to 3,500 women lost their lives last year because of postpartum hemorrhage. Sometimes looks like a number, but if you place these women or the mothers in a bus, you'd need about 60 to 80 buses carrying women or mothers, and all these buses crashing, you lose all these women because of postpartum hemorrhage. So it's a thing that we need to be able to address, especially with the leadership from the African context. And of course, we be able to get help from our friends wherever they will be. But as Africans, we have to really be in the forefront of addressing this particular issue. So we look at this new definition of postpartum hemorrhage, knowing that there have been some changes lately, and then the landmark evidence, and some of our colleagues participated in generating this evidence. And so very simply, I'll talk and touch about it. And then what are these approaches that are there in terms of prevention, treatment, and diagnosis of postpartum hemorrhage? So you be able to relate to this kind of a story, like Mary, 23 years of age, she's para 2, gravid at 2, delivers normally in a rural dispensary, that's a level 2. 10 minutes later, she develops heavy vaginal bleeding. And then at that particular center, she's given oxytocin. But we notice in this particular center, we do not have calibrated drips for collection of blood for accurate estimation, or for accurate measurement of the blood loss. We do not have tranexamic acid. And referral is only initiated when there's significant deterioration of the patient's status. So if I ask you, and feel free to answer this to yourself or to whoever you are close by, which of the delay ultimately determined her outcome? And you can see from this very simple story how a woman can come in to deliver very healthy, but is not able to go back home or not have a baby because of the delays that come because of these particular processes. So the new definitions, and with the conference last week, we had an able speaker, the man behind, the visionary behind the E-Motive, Professor Ari Kumara Asami, who really educated us on the historical background of the definition of PPH and what it really means. But I'll also try to be very simple so that we're able to understand this, that in our conventional definitions, we always used to say, when you have a blood loss of 500 mils or more vaginal delivery, or you have 1,000 mils loss of blood or more in cesarean delivery, within 24 hours, then we say this mother has postpartum hemorrhage. There are many issues that were arising because of this definition, and definitely we were losing many, many mothers because of this definition. And of course, we were able to define what primary postpartum hemorrhage is and what secondary postpartum hemorrhage is. So if you lose this amount of blood 24 hours to 6 months after delivery, 6 weeks after delivery, then this will be defined as secondary PPH. In 2023 to 2025, WHO, with the trials that was also there with the emotive era, they emphasized on objective measurement of blood. And objective measurement of blood will tell you shortly about the importance of the calibrated drips and the other new tools that are coming up in the terms of objective measurement of blood, that any woman who loses 300 mils of blood and has clinical signs and symptoms of hypovolemia, then she qualifies to have postpartum hemorrhage, because at some point we definitely had skewed definition that you have to wait, and most of the time it will be an estimation, not really accurate measurement of the blood loss. So you wait until 500 mils, then you now start putting in the management of postpartum hemorrhage at that particular time. But here we're saying you lose blood as low as 300 mils, but you have any clinical symptoms, then there's need to have intervention. Or if there are no clinical symptoms and one loses 500 mils of blood and above during vaginal delivery or cesarean section delivery, then this will be defined as postpartum hemorrhage, and we need to be able to do bundled interventions that need to be delivered simultaneously, other than what we used to do sequentially. So there's a bit of historical background, and I'll not go into it, about the definitions and how the definition of 500 and 1,000 mils came about conventionally as a group of experts sitting together and coming up with this figure based on their observations versus now the current evidence that have been put across due to the observations of both the patient's dynamics and the patient outputs. So in this landmark trial, the emotive trial that was published, and some of our colleagues appeared in this trial led by Professor Zahida Qureshi, it's a really landmark trial that did a class randomized study in over 80 secondary facilities. And these facilities were in different parts of the continent. We had here in Kenya, in Nigeria, South Africa, Tanzania. And in summary, they observed when they applied this emotive care bundle that there was 60% reduction in severe postpartum hemorrhage, that the patient's losing over 1,000 mils of blood. There was also significant reduction in the patient who required blood transfusion due to bleeding. And they also discovered that with this application of the emotive bundle, that the maternal death significantly reduced as a result of postpartum hemorrhage. The detection rate for postpartum hemorrhage with this particular in this trial rose from 51%, and we were able to now accurately estimate the postpartum hemorrhage to 93% using the calibrated DREPs. And then when there was bundle adherence skyrocketing, due to this care from 19% to 91% when the interventions were delivered simultaneously rather than sequentially. So why is it important that we accurately measure the amount of blood that is lost? So the flaw in subjective assessment of blood loss is clear. I mean, there have been studies that were done with different stakeholders within the labor unit, and you have fluid that is put in gauzes or fluid that's put on the floor, and people are asked to estimate. There was a failure rate of about over 50%, that people were not able to estimate how much volume was actually lost. And so in visual estimation of blood loss, it always underestimates blood loss by about 30 to 50% of the time. And this means in 30 to 50% of the time, you'll not be able to offer interventions because you inaccurately measured the amount of blood that was lost. So then it also creates this issue that we are safe. And because of that thinking that you're safe, you delay in offering care. So you've not been able to recognize shock early. You've not been able to recognize this patient who's deteriorating, and you offer your care a little bit later. Then, of course, when you start treating with this particular estimation, you're doing it sequentially. So you offer one thing, then you wait for a response. There's no response. Then you go to another protocol. And with that, you definitely are losing critical minutes that are important in making sure that this patient is safe. And of course, then there's an issue of blurring of amniotic fluid and urine. So we have inconsistent triggers as a result of managing these particular patients. So it's therefore important that we not visually estimate the blood loss and apply whatever is now within the emotive bundle, that we need to accurately measure the blood loss using the calibrated DREPs. I'm aware there are other tools that are coming up for measurement of blood loss, like the use of the AI calorimetric measures, which I know very soon will be in our units to also be able to use to accurately measure the amount of blood that's lost. So when you're looking at the sequential versus simultaneous approach to management of postpartum hemorrhage, so in the old approach, we used to give an intervention, then you wait, and if there's no improvement, you go to the next level, and then you continuously add up to the number of minutes and the delays that you achieve through this particular kind of care. So in the old approach, the accumulation of severe deaths of blood, of course, patient deteriorating, very likely to go into a disseminated intravascular coagulopathy. And of course, you easily have a mother dying, a mother you'd easily have saved if you had an emotive care bundle that you stimulated, applied, where you trigger the definition either by having the 500 mils loss, or you have the 300 mil loss with abnormal vitals as defined by the WHO, ICM, and FIGO. Then you immediately now get the bundle of care, and this bundle, you want to do it at the same time. So you start with the uterine massage, you apply the oxytocins, you are giving the tranexamic acid, you're giving IV fluids, and you're examining at the same time. And with this, you're saving time, and we are likely to have cessation of hemorrhage before you actually get into disseminated intravascular coagulopathy. So within the emotive bundle, for those of us who might not remember the actual elements within the bundle. So the first is we need to have the early recognition. And now the emphasis is on not visual estimation. We've said we need to accurately measure the blood loss and using the calibrated DREPs. And we need to be able to trigger interventions whenever there are symptoms of hypovolemia or hypotension. Then you have the massage, and as you're doing this, you're expelling any clot or retained products of conception. At the same time, you're applying the oxytocics, and there are different forms of it that you'll be able to apply per protocol. I'll share with you what these elements will be. Then very important, tranexamic acid, you want to be able to start giving this within the critical hour, because if you miss this, then the benefit from tranexamic acid is less and less over time. Then you want to give IV fluids while you're examining, and making sure that if the patient is not improving within the first 15 minutes, you're preparing to escalate this particular patient. In terms of prevention, there have been strong evidence in green here, a little bit of evidence in the yellow, poor evidence in the red. And these are the different options that you're able to give for prevention of postpartum hemorrhage. And here you have from carbetocin, the heat-stable carbetocin, you have the injectable prostaglandins, agometrine. You can have combination treatment of agometrine plus oxytocin, misoprostol, and misoprostol plus oxytocin combination, or oxytocin alone. And so from this, which ones offer some of the best preventive strategies? And you can see from this rankograph and the study done also by and led by Professor Ari, showing that if you have misoprostol plus oxytocin combination, this has a very high chance, of preventing postpartum hemorrhage and very good success outcomes. The second one is having a combination of oxytocin and agometrine, which also gives us a very high chance. And if you're going to use singular medication to prevent postpartum hemorrhage, then use of carbetocin or oxytocin are equally as good. But of course, in a setup where the cold chain and transportation of oxytocin might not be optimal, then of course recommended to use the heat-stable carbetocin, and you have this kind of outcomes. So you can clearly see the combination here is superior to just having a singular intervention. But in cases you decide to use singular intervention, then you can either use oxytocin if you have good cold chain, or carbetocin, as it were. So the WHO FIGO ICM in 2025 recommendation of last year says routine prophylaxis to all women, and it's important. You can give either oxytocin or carbetocin, but based on the cold chain challenges, then heat-stable carbetocin will be superior. And the combination of oxytocin and misoprostol can be considered for prophylaxis of PPH who are at high risk, patients who are at high risk of postpartum hemorrhage in the recommendation of 2025. So briefly on our health metrics, and making sure that we are able to operationalize across from the dispensaries up to level 6, because I know there are some of our colleagues here working level 2, those working level 6. How do we then get to benefit our women, our mothers, so that they receive good care and they not also suffer the places where they cannot be able to receive this care? So if you're looking at the level 2, the capabilities of what people are able to do at this particular level and need for escalation if things are not getting okay. So here we need to be able to have our calibrated reps to accurately measure the amount of blood that's lost. And clearly you can see we are able to do all these interventions from massage, application of oxytocics. We can be able to give tranexamic acid and crystalloids. And we also able to do intervention like by manual compression. And if you're not able to do this within the critical 15 minutes of the start, then we can do pneumatic application and then get this patient transferred to the level 4 hospital. In level 3, you're able to apply the entire emotive bundle in the health centers. And you also have capacity to be able to do uterine balloon tamponade. And we really advocating that all these facilities need to have UBTs instead of using the modified condom catheter. We should be able to get our UBTs, and we can also apply the NASG and then have these patients transferred to the next level if we are not able to get these patients stable for surgery in level 4. In level 4, in the sub-county hospitals, we able to do a little bit more. So the emotive bundle is able to be applied in full, and we're also able to do a good and correct blood transfusion and investigate this patient accordingly. We're also able to do surgical repair, including, getting the uterine artery ligation, application of the breast sutures, the B-linge. We're able to also do the hysterectomy at this particular level. Within these facilities, if there is no success, and normally within the golden hours, we need to be able to activate for transfer either to ICU or having advanced theater or advanced consultants to do the interventions. Then in our national referral hospitals, that are quite a number now, these are the various interventions that can be done, including doing the laparotomy for patients with refractory bleeding. So in our frontline healthcare workers, especially at level 2 and level 3, where most of our women seek care, primarily managed by our midwives and our nurse officers. And it's very important that we emphasize on application of the emotive care bundle within the first 15 minutes and make sure that you're able to detect accurately the PPH and prevent shock from occurring by early referral, because sometimes when these patients are referred late, then we are likely to lose these patients. And in this particular case, we are able to apply the NASG and do the uterine balloon tamponade so that we have life-saving procedures at this particular level before we refer this patient, because it would also be very difficult to refer a woman who is continuously bleeding and you've not put her in the NASG or you've not attempted to offer the uterine balloon tamponade. So with this, the happenings that within the golden hour, you need to have referred this patient. And, so when you notice this PPH, you intervene immediately. And then you're checking within 15, 30 minutes if the bleeding is continuous and is not stopping anytime soon, then you apply either UBT or NASG and get the patient transferred to the next level, mostly level 4. And then within this patient is being transferred to level 4, make sure that you have this maintained, at least IV fluids. You continuously check the vitals and prepare the surgical team at the next level. I know Rwanda, we learned during our conference last week, has a very sophisticated system that whatever you are able to get at level 3, we'll be able to find within the ambulance, so the patient is maintained in a status of stability until they get to level 4 or level 5, where theater is activated and there is massive blood transfusion protocol. So tranexamic acid needs to be offered early. I think that's the point. So we don't want to delay, and we need to make sure that from this care bundle, most of our facilities need to have at least tranexamic acid to be offered to these patients. Every time we delay in offering this critical drug, then we making the chance of survival less and less for each particular minute. It's important also that in our units, we have MOH guidelines and job aids to just continuously remind people of what is PPH, how can we prevent PPH, how can we make a diagnosis of postpartum hemorrhage, and how can we also refer these patients whenever they need referral. So some of them would be like what we've had. How do we prevent postpartum hemorrhage? How do we give oxytocin? How do we give histobocarbetocin? How do we give carbobros, for example? And these charts are very important because for those who are new and coming to our units to help our mothers, need to also be aware of what the management is all like. Then in terms of, when you're giving the emotive bundle, we also need to have this, and we emphasize on simultaneous approach other than the sequential approach to management. And of course, also make sure that people understand the importance of referring the patients early enough before the patients deteriorate further. So we've talked about when you're referring from the level 2 or level 3 that you're able to do give the NASCI, and you're also able to apply the uterine balloon tamponade. And if you do this, then you're able to, especially in the states of uterine atony, to prevent severe postpartum hemorrhage and get these patients to the next level while they're still stable. So these are some of the surgical interventions that might be offered in level 5 and level 6. And we've mentioned from the B-Lynch or the breast sutures, and then offering the uterine or internal iliac ligation, and also ability to be able to offer total hysterectomy. As part of this intervention, for the surgical intervention, our team is coming up with what we call a stitching time, that will be able to train the doctors, the medical officers, and even the consultants who have not been exposed well on how to be able to apply a stitching time using the virtual reality and gamification. So you'll be able to practice how do you apply the right stitch at the corners. If you have persistent bleeding from the edges of if you've done a cesarean section, how do you apply the hemostatic stitch? And how do you do the uterine artery ligation? And you'll be able to actually practice this in an immersive environment where you put no patient at risk while practicing, but you're actually doing the real thing. If you don't do it right way, you have a patient bleeding and you have the patient continuously having the vitals deteriorate. And that's a subject we've started doing on the virtual reality and gamification. And we hope this would really improve what you're able to do. Then, of course, the critical care, where you need to have massive blood transfusion protocol. And I think for level 5, level 6, people need to be made aware of what the massive transfusion protocol is all about. How do we initiate it? How do we maintain? And how do we make sure that the patients are stable and going through it? So,
wow, Prof, feels like you already helped everyone answer the MCQs. Go ahead.
Okay. Sure. So finally, we always need to have audits. And I think from the MPDSR work that has been done and spearheaded by our colleagues, we've been able to really make sure that we have good accountability, good response, and learning every time we have an issue. And this definitely was seen when the emotive trial was being conducted. So as I finish, I must tell you that no woman should die because of postpartum hemorrhage, because we know what to do, and we just need to do the right thing at the right time. So the actionable points for our leaders, from the county health executives to the med soups to who are in charge in the units, and continuously improving our programs and continuously using the emotive care bundle. And I know soon we'll be having the so-called the e-master bundle as well. We should be able to put this in the process and in practice every day. And we hope we can also try to learn this in simulated environment to make sure that our patients are safe. So I invite you for our next run. I see over 1,000 people here. That will be on 27th, not 28th, 27th of September 2026. We'll have the 3rd International PPH run, and we hope we can raise the profile of our run, because it's only true heroes that run for mothers. Thank you very much, everybody.
Thank you so much, Prof. If you do not mind, please put your face on, like your video on, so that we can see the face that has given us quite inspiring data. And we love how you love data and how you used it to create impact and even innovation. Thank you for putting our country on the map. We had the first PPH run, which gave birth to the World PPH Awareness Day, and now we had the first PPH conference. Imagining 60 to 80 buses of mothers dying is quite unsettling. Thank you so much for joining us. And now let's begin following the journey of our patient. Allow me to welcome Sylvia Kimtai from Wasingishu. She has told me it's called the City of Champions. She's going to take us through a patient who delivered in level 2 facility and suddenly begins bleeding. The very first few minutes will determine everything that follows. If you are able to listen to that first mother that we talked about, it is now my pleasure to welcome her. She's an advanced practice nurse candidate, a midwife from Wasingishu County, City of Champions, and a master trainer of EMOC. Sylvia, in postpartum bleeding, we often say, close the tap. Kindly walk us through a possible case scenario in a level 2 facility. What should happen from the very first minute? How do we stabilize this patient? And what can we safely do before we refer? And what are those common mistakes we should avoid? Karibu sana, Sylvia.
Thank you so much, Dr. Mitei, and good evening, everyone. My name is Sylvia, and I'm going to share my experience as a midwife managing a mother in labor in a level 2 or level 3 health facility. We are all aware that before you admit a mother in that lower level facility, it's essential for you to be able to assess and rule out any risk factors that may require senior clinical review or specialized investigations or service that are not available at that lower facility. Identifying these factors early ensures that women who need a higher level of care are referred promptly, hence promoting safe and effective maternal and newborn outcomes. You also need to ensure that you have the required equipment and supplies to manage that woman and her newborn. So I'm going to take you through a few of the essential requirements that are needed in a level 2 or level 3 facility. So number one, you need to have a complete delivery pack. You need to have a resuscitator or a radiant warmer, or if you don't have these, you can just have a corner with some warmer where you'll receive your baby. Then you need to have some calibrated drips to help us measure the blood loss. You need to have uterotonics. Our first line, of course, is carbetocin, but if you don't have that, then you can have the other uterotonics. You also need to have at least some 2 towels and a cup. Of course, one towel is for drying the baby, and the other one is for changing the baby in a dry one. You need to have a maternal resuscitation tray, and you also need to have a newborn resuscitation tray. You need to have a PPH kit, and in your kit, you need to have some large bore cannulas, preferably gauge 16. But if you don't have a gauge 16, then you can have the gauge 18. That is the gray or the green. You need to have IV fluids, that is normal saline and ringers. You need to have some fluid giving sets. You need to have oxytocin and misoprostol. You also need to have tranexamic acid, some strapping, catheters, urine bags, blood sample bottles in the event that you want to refer the client to a higher level facility. You also need to have UBT and NASG in the event that you want to escalate the mother to the highest level. And then, of course, because you'll be monitoring that mother in labor, you need to have your labor care guide. You need to have the blood monitoring chart and the Muse chart. These will be able to guide the midwife on whether they would want to seek consultation from a senior person, or maybe they would want to refer the client to the next level. And of course, you also need to have a PPH protocol on the wall just to be able to guide you. You don't need to cram, but having that protocol on the wall will be able to help you in the event you get a client with PPH. So I'm going to take you through a scenario in one of our facilities, that is Kisor Health Center. We had a mother, Mrs. MSM. She was a para 2+0, gravida 3, who came to the facility with a history of lower abdominal pain and backache. We sought consent and did an assessment on her. The mother had attended 6 antenatal visits. The profile was done. There was nothing abnormal detected, and she was given the preventive measures. On history taking, there were no risk factors identified. And on assessment, it was a term pregnancy in cephalic presentation. Her fetal heart rate was 140 beats per minute, and there was no deceleration. The mother's vital signs, her blood pressure was 126 over 76 millimeters of mercury. Her pulse was 76, and her respiration was 18. The mother was accompanied by a birth companion. Next, please. So on vaginal exam, she was 8 centimeters dilated. There was no caput, nor molding. The baby was in occipital anterior position. The amniotic fluid was clear. The mother had 3 uterine contractions in 10 minutes, each lasting 45 seconds. So we began the labor guide at around 10 a.m. and we also inserted a large bore cannula. We did some investigations. We did a urine dipstick, which showed there was no protein and also no acetone. And her HB was 12.5 grams per deciliter. So feedback was given to the mother, and we encouraged her to ambulate, take her meals, and also take plenty of fluids. At around 1 p.m., the mother had an urge to bear down. On vaginal exam, she was 10 centimeters dilated. The calibrated drape was applied, and the mother was encouraged to bear down. At around 1:30 p.m., she gave birth to a female infant who scored 9 at 1 minute, and the immediate newborn care was done. Next slide. Yeah, so we ruled out a second twin, and carbetocin 100 micrograms was administered within the first 1 minute of birth. We did delayed cord clamping for 3 minutes. The placenta was then delivered by controlled cord traction, and on examination, the placenta was complete. We did a uterine massage for 1 minute and examined the cervix, the vagina, and the perineum, and there was no tear noted. The blood loss at this particular time was 350 mils. We did her vitals. Her BP was 120 over 72. Her pulse was 90, and her respiration was 20. So we continued to monitor the mother as per the blood monitoring chart. So we monitored the blood loss, we monitored the tone, and then the vital signs, that is the BP, and the pulse and respiration every 15 minutes. So at 1:45 p.m., the uterus had not contracted, and the blood loss was 400. When we took the vitals, the pulse was 110, and the BP was 110 over 68. So because of the blood loss of above 300 and one a clinical sign, which is pulse, we diagnosed a PPH. I shouted for help, explained the situation to the mother, and then we went ahead and triggered the WHO Fast Response Bundle. Next page. So what we did, so as we were waiting as I was waiting for the other midwife to come, I massaged at the uterus to stimulate a uterine contraction. So when my colleague came, I requested her to do bladder catheterization to empty the bladder. And then the one branula that the mother had, we started oxytocin infusion of 10 IU in 500 mils of normal saline, which was infused for 10 minutes. And then on top of that, we gave MISO 800 micrograms sublingually as an additional uterotonic agent. And then when the 10 IU was over, we again put up another 20 IU of oxytocin in a liter of normal saline, which was infused for over 4 hours to maintain the uterine tone. We also inserted another large bore cannula, and we took some blood as samples for GXM, CBC, and clotting profile. And then we also administered tranexamic acid, 1 gram slowly over 10 minutes. Then we also put up IV fluids, normal saline a liter, which was infused over 20 minutes. Next, please. So we continued to monitor the mother as per the blood monitoring chart, where we were looking at the uterine tone, the blood pressure, the pulse, and also the blood loss every 15 minutes for the first 2 hours, and then every 30 minutes for the next 4 hours. At around 1 p.m., the uterus was well contracted. There was minimal blood loss noted. The pulse was 86. The blood pressure was 108 over 68, and the respiration was 20. So we continued with the 20 IU that we had started initially to run for the next 4 hours, and we continued monitoring the mother as per the blood monitoring chart guidance. So we did our documentation on both the cardex and the blood monitoring chart. And when the mother was stable enough, we sought consent on providing essential newborn care to her infant. Next. So the other slide, yeah. So when we were doing our first examination of the baby, we found out that the baby seemed jaundiced, and because we were in a lower level facility, we made arrangements to refer the baby to our level 4 facility with consultation with the mama. So a call was made to our call center requesting for an ambulance, and another call was made to our level 4 hospital, which is Mama Rachel Ruto Maternity Hospital newborn unit. So our situation was that we were having a baby with jaundice. The baby was a female infant who was birthed 4 hours ago through a spontaneous vertex delivery with a score of 9 at 1 minute and 10 at 5 minutes. The mother developed PPH, but was managed well with the first response bundle with good response and outcome. On assessment of the baby, the vital signs were temperature 36.7. The pulse was 125. The respiration was 50 breaths per minute. The SpO2 was 94. Baby was breastfeeding well. And we had also given the essential newborn care, which was TEO, CHX, and vitamin K 1 milligram. So our recommendations being in a lower facility, we wanted some investigations to be done on the baby. That was bilirubin levels, LFTs, CBC, and of course, for possible phototherapy in the newborn unit. So the mother and the baby were transferred to the level 4 facility at 6 p.m. And the mother was in good condition. So in summary, we are saying that it's possible for us to be able to manage. Next slide, please. So it's possible for us to be able to manage mothers at level 2 and level 3 facilities with good maternal and newborn outcomes. But it's also appropriate for us to do a proper risk assessment for us to determine the most suitable place of birth and also ensure timely referral when needed. Preparedness of preparedness for PPH is very critical, and this includes having a PPH kit readily available and also following the standardized PPH management protocols, and also just ensuring that prompt diagnosis is done through the use of a calibrated blood collection drips and also regular monitoring of the vital signs. Just remember, colleagues, that 94% of women with PPH can be saved by simply applying the first WHO response bundle to the end. And the only way for us to do that is for us to be able to diagnose a PPH. And of course, the only way for us to do that is to ensure that we are having the calibrated drips, and also just ensuring that we do our vital signs more regularly. Thank you. And back to you, Dr. Mitei.
Thank you, the lady from the City of Champions. You couldn't have done it any better. I love that you were able to save this mother at the dispensary. Now, I'm imagining if we were not able to control the bleeding despite our efforts, some patients will require referral to a higher level of care. It is now my pleasure to invite Dr. Francis Mungai. He's a medical officer at Kerugoya County Referral Hospital in Kirinyaga County. He's also a master national trainer of trainees in EMOC and also an author of a very great book that I've had the pleasure of reading, Afraid to Hope, Tales of a Midwife Tormented by a Silent Womb, in which he highlights the plight of women during pregnancy, labor, and delivery. Dr. Mungai, our patient has now arrived at level 4 facility. Kindly take us through the likely presentations of postpartum bleeding at this level. How do you rapidly identify the cause, organize an MDT, initiate resuscitation and definitive management while still recognizing when further escalation becomes necessary? Karibu, Dr. Mungai.
Thank you very much, Dr. Mitei. So thank you, team, and everyone. Welcome. So very much welcome to Sylvia for the great work that you are doing in level 3 and all the other healthcare providers in lower facilities. That is great work. I'm here to present a case scenario that did happen in a level 5 facility and how you can go about in managing. Sylvia just finished by saying that 94% of all mothers with PPH can be managed by applying emotive. But some women will apply the first response bundle and they'll continue bleeding. I'm here to show what else can we do. Some of these things might appear repetitive, but they are for emphasis purposes. I'll give a case scenario and take you through how we were able to manage the patient. So the patient that I'm presenting, her name is MWM. She was a 26-year-old lady who presented to us on 16th of April 2026 at 1400 hours. She was a gravida 2, para 1, para 0, and she presented to us at 39 weeks and 5 days. She had attended one ANC clinic at 22 weeks, whose booking had a HB of 9.4 grams per deciliter, while other parameters were normal. At admission, we repeated the HB and it was at 9.1 grams per deciliter. She presented to us, let us move to the next slide. She presented to us with low abdominal pains for 1 day that was increasing in intensity and frequency, was reported to be radiating to the lower back, was associated with drainage of clear liquor that had started 2 hours prior to admission, that was flowing along the inner thighs to the floor. The liquor was not for smelling. The patient reported to perceive normal fetal movement at the point of admission. When we did the general examination, let us move on. We noticed that she was in fair general condition. She was not pale, she was not jaundiced, she was not dehydrated. However, she had bilateral and pitting edema to the level of mid legs. Her vitals, all of them are within normal range. The blood pressure was at 128, 72 millimeters of mercury, a pulse rate of 92 beats per minute, a temperature of 36.7 degrees Celsius, and a random blood sugar of 5.9 millimoles per liter. Upon doing abdominal examination, we noticed that the father height was at term. Let us move on. The abdominal examination revealed that the father height was at term, the lie long was longitudinal. She had a cephalic presentation, a descent of 3/5. We were able to palpate 3 uterine contractions in 10 minutes, each lasting 40 seconds. And at that moment, the fetal heart rate was 138 beats per minute. BPP revealed was 10 of 10, estimated fetal weight of 900 grams, and placenta was reported to be fathers. The cervix, that is on vaginal examination, was 7 centimeters dilated. It was central, thin and soft. At that moment, we made an impression of Apala 1 plus 0, Gravida 2 at term, in active phase of labor. So the patient was monitored using the labor care guide in the active first stage of labor. And at 1900 hours, she got to the second stage of labor, the non-pushing phase. At 1930 hours, she developed the urge to push. And at that moment, we applied the blood loss monitoring drip that Prof was alluding to. We applied it at this moment. At 1950 hours, patient delivered live male infant for 100 grams. The baby scored well, an APGAR of 9 at 1, 10 at 5, and 10 at 10. After the delivery of the baby, we got to the third stage, which we did manage actively. This is a bit of repetition. Sylvia also did a similar thing. It's good that we may get how to manage that stage of labor actively. You'll be told why later on. But we did administer uterotonic. We gave 100 micrograms of heat stable carbetocin after ruling out the second twin. And we assured we gave this uterotonic within 1 minute of delivery. At that moment, we opened the calibrated blood loss monitoring drip to collect the blood that the patient was to lose. Now that the mother and the baby were stable at this moment, we were able to delay the cord clamping and cutting for a whopping 3 minutes. After that, the placenta was delivered by controlled cord traction and uterine massage done immediately after the delivery of the placenta. We also did expel all the clots, examine the perineum for any tear, and examine the cervix for tears, and none of them had a tear. This is the calibrated blood loss monitoring drip that we have been alluding to. It looks like that. The bluish part is normally applied on the back of the patient. Then it is placed in a manner that the other part hangs at the foot of the bed. It is meant to collect every blood that the patient loses. And at the lower side, you can see that it is calibrated. At 300 mils, it is marked yellow, and at 500 mils, it is marked red. And we use it for the objective assessment of the amount of blood lost. Then on the other side, we have a picture of heat stable carbetocin. This is the uterotonic that we did administer. But as Sylvia alluded, if you don't have heat stable carbetocin, you can as well use oxytocin or the other drugs. Let us move on. Now that our patient had delivered well and we had managed the third stage of labor actively, immediately after delivery, it's always encouraged that we keep monitoring the mother, and this is our monitoring post-delivery. The aim was to keep monitoring the uterine tone, to monitor the blood pressure, monitor the pulse rate, monitor the respiratory rate, and the objective blood lost. The aim was to monitor these vitals or parameters every 15 minutes for the first 2 hours after delivery. Then after that one, we were to monitor every 30 minutes for the next 4 hours. So in total, we were to monitor the patient for 6 hours. Everything that we were to monitor was to be documented on the chart that is on the right. That is the blood loss monitoring chart, the postpartum blood loss monitoring chart. When you go to the next slide, let us get to the other slide. You can see the chart where we called it postpartum blood loss monitoring chart. It looks like this. It tells you it is for complete routine postpartum assessment. It tells you that includes the blood pressure, the pulse rate, the objective blood lost, the uterine tone, and any current bleeding. And it tells you very well that ideally you are supposed to monitor every 15 minutes for the first 2 hours, that is 8 times, then every 30 minutes for 4 hours, that is also 8 times. So in total, you're supposed to have at least 16 documented readings on this chart. It goes ahead to tell you what an unstable patient is or what abnormal finding is. It tells you what an abnormal pulse rate, what an abnormal blood pressure is, what an abnormal uterine tone is, what an abnormal vaginal bleeding is, and what abnormal objective blood loss is. And there down, it tells you when to trigger the first response BADO. So by proper use of this chart, the postpartum blood loss monitoring chart, you can be able to detect. That's what we're emphasizing on, early detection of PPH, so that you can administer the BADO. And you're told that trigger first response BADO of PPH management if cumulative objective blood loss is more than 500 mils, that alone you trigger, or if the objective blood loss is 300 mils with at least one other sign or one clinical judgment. And that one other sign, it is what has been explained above as an abnormal finding. It's good that we may have this chart in all our files. Our patient is monitored using that chart, and at 10 hours, that is 20 minutes of delivery, we noted that the uterus was soft and boggy. She was experiencing heavy vaginal bleeding, and at that moment, the objective blood loss was at 600 mils. The blood pressure was 102, 70 millimeters of mercury, a pulse rate of 110 beats per minute. At that moment, we made an impression of postpartum hemorrhage. We called for help, and we're able to assemble a team. I'm in a level 5 facility, so we're able to bring a team together, and a senior midwife took the team leadership. However, the medical officer was available too. Other nurses were available and were able to inform the obstetric gynecologist at that moment. Then we went ahead and we did activate the emotive BADO, or what we are calling the PPH management protocol. This is the protocol that we did administer to the patient, that we had been able to make an early detection because of using the VDRIP and using the postpartum blood loss monitoring chart. That enabled us to make an early detection. And as soon as we made that early detection, we inserted a second cannula, during which we took laboratory samples for full hemogram, UECs, and GXM, and also able to do a coagulation profile at that moment. Then one person was assigned the role of uterine massage and massage the uterus at the furthest for 1 complete minute. Another person was assigned the role of urethral catheter insertion, inserted an indwelling catheter, and was able to evacuate 300 mils of urine. Another person, well, we remember you were able to assemble a team, a multidisciplinary team. So people are getting assigned roles by the team leader, who is a senior midwife. Then now now that we are having 2 IV cannulas, we were able to give this medication on one line. Within the first 10 minutes, we were able to give IV oxytocin, 10 international units, in 500 mils of normal saline, which we did run in 10 minutes. While that one was running, the other hand, we were administering tranexamic acid, and aim was to give 1 gram in 10 minutes. It's normally 10 mils, so it's ideally 1 mil per minute. Then after the first 10 minutes were over, the line that was giving IV oxytocin, we were able to start 20 international units of oxytocin, in this time in 1 liter of normal saline. And the aim for this one was meant to run slowly for 4 hours. So it's good that we get how to give that oxytocin. And also at that moment, we're able to give misoprostol 800 microgram sublingually. Then the second line that had been giving tranexamic acid, we started IV fluid for hydration. The aim was to give normal saline at a rate of 1 liter within the first 20 minutes and the second liter within the next 30 minutes. So that was our first response BADO that we give. And as Prof alluded, is that the aim was to give all of them together, not giving one and waiting and see. The aim was to give all of them together. After we were able to administer the first BADO, we went to examination. Remember, we have done emotive up to IV. At E, that is examination, we still examined the uterus, noted it was still boggy. at 20 weeks of gestation, patient was still experiencing heavy vaginal bleeding, and at that moment, the objective blood loss was at 950 mils. So meaning we had not yet achieved hemostasis. And upon the examination of the 40s, there was no perineal tear. This was confirmed, and there was no cervical tear. Remember, we had examined again during the active management of that stage of labor, but this was to confirm whether we had missed any. However, there was still no perineal tear noted, no cervical tear noted. Placenta was examined again and was still noted to be complete. And at that moment, the platelet had come back and platelet count was within normal range. At that moment, we need the impression of refractory PPH, secondary to uterine atony. So having made the impression of refractory PPH, we escalated the care of this patient and we gave a second dose of tranexamic acid. This we say that if 30 minutes have elapsed after giving the initial dose of tranexamic acid, you can give a second dose of tranexamic acid, and the dosage is still 1 gram slowly over 10 minutes. If you're not given a second deuterotonic, you can also give it at this moment, but for our patient, we had already given sublingual misoprostol 800 microgram. We had informed the consultant obstetrician earlier on. However, we still called them and actually requested them to come and join us. And as we called them, we used the ESBA. Remember, it is a tool for communication in our care. It's still the same tool that Sylvia did use when she was trying to refer the baby. So the ESBA, the situation in this scenario was refractory PPH, secondary to uterine atony, a background of a 26-year-old MWM, now para 2, who delivered 45 minutes ago into a 4100 gram male infant who scored 10 at 5, had anemia at a dimension of 9.1 grams per deciliter. The analysis was that PPH had been noted and coded, where the blood loss was at 600 mils and a pulse of 110 beats per minute. Emotive had been administered. However, she was still bleeding heavily with a soft uterus at 20 weeks, a blood pressure now at 96/60, and a pulse that had risen to 120 beats per minute. And the recommendation why we were calling the consultant obstetrician gynecologist was to come and help us in escalation of the PPH management and the potential surgical intervention. However, as the consultant was coming and the patient was bleeding heavily, there are some things that we continued doing. And this is other escalation measure that we did. Now that she was bleeding profusely, the first escalation was to compress the abdominal aorta. We did explain to the mother that we needed to compress her abdomen with the aim of compressing the blood vessel that does supply blood to the lower part of the body. So we explained to her, we gave her the rationale, and she gave us the consent. We palpated the left femoral artery. This one, I'm the one who did it. Palpated the left femoral artery with a non-dominant hand and kept it there. That is to get the femoral pulsation. Then immediately after that, using the dominant hand, my aim was to identify the umbilicus. First, I went to the umbilicus and palpated the abdominal aorta, left the vertebral column. I made a fist with the dominant hand with the thumb outside. Then press the pulsating abdominal aorta until the femoral artery pulsation stopped. So the dominant hand was compressing. We can go to the other slide. The dominant hand was compressing the abdominal aorta, while the other non-dominant hand was trying to assess the femoral pulsation. This is only successful when you can no longer feel the femoral pulsation. So you want to compress here until you cannot feel the femoral pulsation. For this one, I did retain this compression until we were able to do the second escalation, which is in the next slide. Let's go to the other slide. This was the other escalation that we did, and it involved the insertion of the free flow uterine balloon tamponade. The aim of this one, you want to inflate a balloon within the uterine cavity so that it can compress on the placental bed to try and achieve hemostasis. We did explain to the mother too, and she gave us consent. We opened this was being done by a midwife. We opened the UBT in a sterile field, filled the bag with 1 liter of distilled water. We hung the bag at 1.5 meter high, identified the cervix, and inserted the UBT. The heart that does do the the vaginal examination and identify the cervix is meant to be left there. As the valve gets opened and the bag fills, the aim is to ensure that as the balloon is filling, it doesn't slide back into the vaginal canal. Once we were able to inflate the balloon, after 45 seconds, we removed the head from the cervix. The balloon was well secured within the uterine cavity. At that moment, we marked the fathers of the uterus and continued monitoring quarter-hourly. At that moment, the compression of the abdominal outer stopped. There's a slide that you have skipped. At that moment, the compression of the abdominal outer was stopped. Now that the UBT was in situ. The other escalation that we did as the obstetrician gynecologist was coming is that we applied an pneumatic and shock garment. The aim of this one, we want to compress the peripherals to shunt blood from the non-vital organs to the vital organs. So we informed the patient, she gave us the rationale. We took the baseline vitals and 2 people applied this garment. You can see a photo of it there. This is not our patient, but that's how it looks like.
Thank you so much, Mungai. Kindly wrap up.
Yes. The aim of this one is to compress blood from the non-vital organs to the vital organs. So we were able to do those escalations. And as we continued monitoring the patient, the aim was to continue monitoring every 15 minutes. And remember, we had the V drip, the calibrated drip was still in situ. At this moment, we were having 20 international units of oxytocin still running. And reviewed at 15 minutes and 30 minutes, revealed that the vaginal bleeding was actually reducing. The father height had decreased from about 20 to 12 weeks, and the vitals had improved. The blood pressure had risen to 110, 76 millimeters of mercury, and a pulse of 16 beats per minute, coming down all the way from 120. At that moment, we considered to had managed the PPH successfully. So the take home of the things that we need to emphasize on is anticipation and preparation, ensuring that you have a complete PPH kit before every delivery, and you have a PPH protocol that is emotive. Then there's a role of prevention that can be done during ANC and also during the active management of that stage of labor. Then it's important that you do early detection that you can do by use of postpartum blood loss monitoring chart and the VDRIP. And if you make an early detection, kindly administer the PPH protocol, that is the emotive, and escalate measures appropriately, including an established referral system and early enough acquisition of blood products. Teamwork is very important, and timely consultation and referral are equally very important for you to manage PPH adequately. Thank you very much, team. Thank you, Dr. Mitei and team. That is how we manage the patient.
That was amazing, and just looping through the importance of the things that Prof even mentioned when he was doing his keynote speak. The drape is very important. Preparation was highlighted by Sylvia, and you have said the same thing. Prevention is key. However, if we have prevented and we did not succeed, or maybe the mother reached us and we were not able to prevent, you mentioned one of the things is to actually involve a multidisciplinary team. And you mentioned calling or looping in a consultant. It is now my pleasure to welcome Dr. Maureen. She's a consultant obstetrician gynecologist and also a fistula surgeon and a master national EMOC trainer based at Vihiga Teaching and Referral Hospital. Dr. Maureen, having listened to Sylvia and Dr. Mungai, take us through the management of postpartum bleeding across different levels of care. Kindly guide us through the escalation to surgical management. Help us understand when conservative measures are failed, how do we make timely surgical decisions and the principles that should guide surgical management before the patient reaches physiological collapse. Thank you and welcome, Dr. Ari. Please take it away.
Thank you, Dr. Mitei, for the kind introduction. So I'd like to start us off with a diagram of a mother who has just delivered. As you can see, the uterus is still very much distended with a lot of blood. And you can see some of the reasons why. We can see a patch of placenta, and you can see that the uterus is not contracted. Next slide. So this definition has already been given to us by Prof. I may not want to delve so much into it. You have the conventional of 500 and 1,000 for vaginal and CS delivery consecutively, but also don't forget any blood loss that will cause physiological changes. And hemorrhage actually accounts for about 40% of maternal deaths. The next slide is from KHIS, and it is just to show us the burden of PPH that we have as a country. PPH on its own is depicted by the orange column. That is the second one. Right from 2017 to now 2025, which was last year, we can see that the numbers are actually increasing. In fact, the numbers for last year was higher than the 2 previous years. And that is why we are having this conversation, because PPH is still a problem in our country. Next slide. These are the 4 main causes of PPH, with the tone accounting for majority at 70%, followed by trauma at 20%, tissue that could be retained placental clots at 10%, and 1% for thrombin. And don't forget that the patient can have more than one cause. That is why examination and escalation is very important, and that will form the core of my presentation. So we cannot talk about PPH and not talk about the risk factors. You have to anticipate it. The patient presented by my colleague, Dr. Mungai, had anemia in pregnancy with that HB of 9. So that already on its own is a risk factor. The other risk factors are pre-existing coagulation disorders, APH, any condition leading to overdistension of the uterus, whether it's a big baby, polyhydramnios, multiple pregnancy, uterine fibroids, and it's because this uterus is way overdistended, so contraction becomes an issue. When it comes to prolonged labor, induction, and augmentation of labor, they lead to myometrial fatigue, which again is a risk factor for atony. Previous placenta previa or retained placenta or CS are also risks. Any patient with an infection, sepsis, is at risk of atony, at risk of DIC and endothelial damage, and all this increase the risk of PPH. Full bladder is also something that needs to be considered. So we cannot talk about PPH without talking about active management of third stage labor. It has been covered by my colleagues, but I just want to mention that the incidence of PPH can be reduced by 60% if you apply Amstil well, and it also reduces the quantity of blood lost and the need for blood transfusion. That is why it should be included in any program of intervention aimed at reducing death from PPH. I will not go through the 4 components. Next slide, because my colleagues have talked about them, but I have an algorithm borrowed from the obstetric protocol in the next slide that I would like us to focus on. The blue part here shows the Amstil part. But now what happens if the placenta is not delivered? If it's out, you can examine it. If it's not out, you empty the bladder, repeat controlled contraction, and if in 30 minutes it's not yet out, you may have to remove it manually, add antibiotics, and by this time you have already started the PPH emotive bundle and escalated if need be. The next slide is also on heat-stable carbetocin. We have already been told about the uterotonics that can be used in Amstil. I just want to highlight something small about heat-stable carbetocin, that the dosage is 1 ml, which is equivalent to 100 micrograms. This can be given as IV or IM and never injected into the fluid. I'd also like to mention, as the name suggests, that it is heat-stable. It does not require refrigeration. Actually, literature tells us that it can be stored at 30 degrees for 48 months. That's 4 years. And obviously, always check for expiry of any drug that you're going to use. Which women cannot use heat-stable carbetocin? You cannot use it for induction or augmentation of labor. If the mother is still pregnant, don't use it in cardiovascular disease, hypersensitivity to carbetocin or oxytocin. Don't use it in hepatic or renal impairment or in women with epilepsy. So proper history is very important before you administer it. When you compare it to oxytocin in terms of duration of action, in the next slide, we're going to see that carbetocin lasts 4 times longer compared to oxytocin when given intramuscular. The duration of action is 119 minutes vis-a-vis 30 minutes of oxytocin. Next slide. So this woman has bled and is still bleeding, and we are escalating. As we're escalating, we want to diagnose shock. So what are some of the signs and symptoms? These are familiar to us. There's pallor, there's going to be an increase in the respiration and pulse. There's going to be confusion or agitation. The blood pressure may be low, and this is a late sign. Also, urine output may be affected. Always remember that the bleeding may not be obvious. The patient could be having more bleeding than you can see. So you have to really look at the vitals. Clamminess and cold extremities can also be there, and the woman dies from lack of oxygen to the vital organs. So how will you know how much blood a woman has lost? By the time, if the woman had a good HB, she may lose up to half a liter and be asymptomatic. But by the time the blood pressure is affected, this is a woman who's lost almost up to 2 liters. So you do not want to wait that long. Learn to close the tap early. Next slide, please. So this chart, the modified early obstetric warning score, is also a very important tool that can help us monitor our mothers after delivery. It is very user-friendly. It has a key that can be referred to. And in some centers, they have color-coded it, but this one is also very much practical. The main things it checks is the respiratory rate, the pulse, systolic BP, and diastolic BP. Chart whatever is reading from the patient, then add the score. Any score that is 0 or 1, you can just repeat. You can routinely monitor this patient. If it's 2, you may need to repeat in 30 minutes. But any score of 3, you need to escalate and even refer this patient depending on where you are. Next slide, please. So this is this algorithm again is from the obstetric protocol. I want us to focus on this part here. You have done your E motive up to the last E. The patient is still bleeding. You have examined and you're thinking of escalation. So the patient is still bleeding, yes. Your first option is non-surgical maneuvers, which Dr. Mungai spoke about. And then if those ones fail, you want to go to the surgical interventions. And we are going to see those examples in the next slide. So by the time you want to manage PPH, you have to be prepared. You have to have a protocol or standard operating procedure. Nationally, we are using the E-motive. Drills are very important. They help know our readiness. It's a multidisciplinary team. You need the kit that is well equipped, blood and blood products, and that my next presenter is going to elaborate more on. And you just need to be prepared, even emergency-wise, and everything that is needed to do with PPH. So in the initial management, next slide, please. You want to, first of all, reassure the mother, briefly explain what is going on, shout for help, make sure that you have the PPH kit that is well equipped, do a rapid assessment, and as already done in the previous lower level facilities, the E-motive bundle was started. Always appoint a team lead. Next slide, please. So on the examination, the patient is still, the uterus is still atonic. We've checked for tears, there are none. And the reason why this patient has been brought to level 5 and also referral facilities because the bleeding continues despite the medication in E-motive and the non-surgical maneuvers. The cause is unclear and we also are unable to manage the bleeding. So what does escalation mean? So before that, Mungai finished by saying that this is refractory PPH, and that is because the woman has continued bleeding despite institution of first-line treatment. Additional help is needed, and this time round you need expertise help because you're thinking of surgical maneuvers. You've already repeated your tranexamic acid. So as we mentioned earlier, you have to start with the non-surgical ones, which you're going to see diagrams on. And also before you go to the surgical ones are the hemostatic, such as systematic pelvic devascularization and subtotal hysterectomy, which I will talk a bit on. So previous slide, please. Previous. Yes, thank you. The one on the algorithm. Yes. So, okay, there's the slide before this one is talking about initial management, which is on which it should happen for any patient who is bleeding. Please take us to the previous slide. Yes, that one. So you have to start with danger, assess for danger, check for response. Is this patient breathing or not? If not breathing, you need to open the airway using the airway opening maneuvers, whether it's head tilt, chin lift, or even the jaw thrust. Check for breathing. If the patient is not breathing, you need to assume arrest and to start CPR at the rate of 30 to 2, and make sure that you have your resuscitation equipment ready. And always ensure the airway is open and the woman is breathing. If not, you start resuscitation and you give oxygen. If breathing, start oxygen by mask. So in the next algorithm, it talks about a mother who is also pregnant. So I want us to just focus on the chest compressions and on the airway. Remember, this woman has already delivered. So we said if you're alone, you start chest compressions, you do CPR until help arrives. When help arrives, part of the help you have called is even anesthesia team. You can have someone as you give the 30 chest compressions, someone else can give 2 ventilations. The anesthesia team can help secure the airway. And this is a patient you're thinking of going to theater. So even in theater, it is easier to do a GA, so the intubation needs to be in place, and the anesthesia team is taking care of the airway as you plan to do definitive management on this patient. The same anesthesia team will be able to give pressors depending on how the patient's vitals will be. So we proceed. And we can see that some of the diagrams by manual compression, this one was already done before. As you can see, one hand on the fundus and the other on the anterior wall of the uterus. My colleague talked about the free flow UBT. This is the condom one. It is a modification. Just maintain sterility, use antibiotics. And that is why we also use using sutures to tie it. On the next slide, we are going to see so all that has failed and you've gone to theater. You want to do definitive management. Remember, the cause is atony, which causes 70%. So with billing suture, this one is the one that we mostly practice, and it is done as you need an assistant, usually done during a CS section or after the cesarean section. And that is why you can see the incision there. So you need a long suture, and sometimes you need to straighten out the needle so that you're able to go through and through, loop it over the fundus, then over to the other side and come. That's the way it is depicted in the diagram. Your assistant needs to press on the uterus to attain a good tone before you close the incision, and then you make the tie. And as you can see, after it has been done, the bleeding should actually reduce by the time you have done that. The other modifications are like Hayman. Hayman is done maybe when you've not done a CS, you don't need to do an incision. And in Hayman, you find that the knot can be at the fundus or at the lower segment. If you're concerned about bleeding from the placenta accreta or placenta previa, you can add horizontal sutures. The others are not so common, but for those who practice them, this one is just box sutures that are done through and through the entire wall of the uterus through the endometrium. And in Pereira's, it's done on the serosa only, again with pressing on the uterus to attain a good tone. It doesn't go through the endometrium, so theoretically will lead to less infection. And all these sutures are absorbable. If you do the brace sutures and they don't work, there's also an option of systematic pelvic devascularization on the next slide. The first diagram is showing us just the uterine artery as it branches off from the anterior branch of the inferior hypogastric. And as you can see in the second diagram, you have been shown where the ligation can be done. Remember to retract the bladder caudally so that you do not cause any injuries. And another thing that I'd like to mention, this internal iliac artery, when we will come to talk about NASG, and it says that when you use a NASG properly, it's like ligating the internal iliac directly. So we can go to the next diagram where we are going to talk about subtotal hysterectomy. If all these fails and the patient is still bleeding, there is room to do subtotal hysterectomy, whereby you're just coming out with the body of the uterus. You are not touching the ovaries because you do not want surgical menopause. At the same time, it is supracervical, having dissected the bladder down. For our colleagues who are able to do a transabdominal hysterectomy very quick, it's also acceptable, and you can come out with the entire uterus, including the cervix. So you have done all this, and this needs to be done timely so that the patient does not continue bleeding. The last part of my presentation, I'd like to quickly go through the NASG, which has been mentioned by my colleagues. As the name suggests, it's an anti-shock garment. On the next slide, we are going to see the main concern that makes you use it is for a patient who you're suspecting could be going into hypovolemic shock. So what does a NASG do? A NASG would, next slide please. A NASG before we come to that, let's talk about obstetric hemorrhage. This slide is very important. NASG is not only for PPH. If you have a mother with placenta previa, abruptio, or even a ruptured uterus, or early pregnancy bleeding, whether it's ectopic, molar, you can still use a NASG because the enemy here is hypovolemic shock. So we can now go ahead and see what exactly it does on the next slide. It will help you to stabilize the patient as you evaluate and you transport or you prepare for definitive surgical treatment. That means even if I'm in a referral facility, I can apply the NASG as I wait for the theater team to assemble, as I wait for the equipment to be ready. And it can be safely used up to 72 hours, though the mean treatment hours is 6 hours. When you apply it well and in the right time, you may reduce the risk of hysterectomy and even blood transfusion. And usually it will reduce arterial perfusion pressure, and it's comparable to ligation of the internal iliac. If a patient on NASG has difficulty in breathing or reduced urine output, you may need to slightly loosen segment 5 and 6. So we'll talk about the mechanism of action. When shock is decompensated, the vital organs will be deprived of oxygen and blood is accumulated in the lower part of the body. And it's the same scenario in obstetric hemorrhage. Blood leaves through the body through the vagina and pulls in the retroperitoneal area. But now when you put in an NASG, it provides a circumferential compression of the abdomen, the legs, and this reduces the volume of blood in the compressed areas. So generally you reduce the caliber of the blood vessels, and with that reduced caliber and radius, even the blood flow through the vessels in the legs are reduced, as you can see in the diagram below. It's important to note that you can do procedures, vaginal procedures with an NASG in situ. From the diagram, you can see that the stirrups can still be put. The patient is not immobilized, and you're able to do whether it's repair of episiotomy, manual removal of placenta, anything, including by manual compression or even putting the balloon tamponade that you already mentioned. You can do all this with the NASG in situ. So let us prioritize using it. We can also do abdominal procedures, as you can see in the next slide. With abdominal procedures, you only open it, the abdominal segments, when the theater team is all set. Maintain the leg panels, don't remove them. And then, so when you have already cleaned and you're just about to cut, that is when when you're just about to clean is when you open the abdominal sections. Before you touch the abdominal sections, ensure the anesthesia team is ready with fluid boluses, and now you can perform the surgery. So after the operation and you've put in your dressing and your strapping, you can close the abdominal segments, and please ensure the NASG stays put for 2 hours post-op, regardless of the patient's vitals. Even if they are stable, maintain the NASG for at least 2 hours. And this is an example of abdominal procedures on the next slide. I'm about to wind up. So all these procedures, whether it's a C-section, ruptured uterus, hysterectomy, salpingectomy, they can all, including ligation of the uterine arteries that we talked about. You can do all this with a NASG in situ. So you just open, do the procedure, then you replace the abdominal segments. The leg panels are maintained. So the NASG seems magical. Where my colleague said when putting it on, you ask for help even from the people who are nearby. But when it comes to removal, this is very technical and it needs a skilled healthcare provider. IV fluids have to be running. Always use the rule of 20, which is if the systolic BP drops by 20 or the pulse increases by 20, you replace the segment that you had opened. The removal can only begin when the woman is clinically stable for at least 2 hours. And more often than not, the woman will have had it for at least 6 hours. So ensure the bleeding has decreased to less than 50. We still have the drape, I believe. The pulse is less than 100, systolic BP above 100, and the patient is conscious and aware. So what does the NASG do? As magical as it is, the NASG, just because the patient has a NASG, it does not mean that you will not evaluate and identify the cause of shock. You still need to continue with the uterotonics, including the 20 IU of oxytocin in 1 liter that was running for 4 hours. and UBT if the patient needs it. The fluid and blood replacement needs to continue. If she had a coagulopathy, you need to take care of that. And any standard care treatment of hypovolemic shock needs to be taken care of. So that is the end of my presentation. In conclusion, PPH management can be initiated from all levels of facilities. And as I mentioned this, remember, Prof. Bimbo also added that even in level 6, you can do uterine artery embolization if the facility is able to support that. And the patient must be stabilized at whichever level the PPH happened prior to referral for definitive management. These are my references, and I leave you with a quote from the late Mahmoud Fadhala in the next slide, that women are not dying because of diseases we cannot treat. They are dying because societies have yet to decide their lives are worth saving. Thank you.
Thank you so much, Dr. Maureen. That statement really resonates, and I hope we do not lose any more mothers from postpartum bleeding. Now, I'm imagining as we've been listening to these presentations, the reason why we are very attentive is because there's something in our bodies that are circulating oxygen. Now, imagine without that blood, even the best surgeon cannot save a life. Whether I have enough blood as a client or whether I've lost blood enough to even make my vitals unstable. Now, it is my pleasure to introduce Mr. Dennis Oduor Brutus, a medical laboratory professional and public health specialist with over 10 years of experience in laboratory medicine, blood transfusion services, and public health. He currently serves as the chairperson of CBTC's caucus and the county blood services coordinator for our city, Nairobi County, where he coordinates blood donation, blood availability, transfusion safety, and emergency blood preparedness programs. Dennis is a passionate advocate for voluntary blood donation, transfusion, patient safety, and strengthening blood system to support maternal health, trauma care, surgery, and other life-saving interventions. He remains committed to advancing universal health coverage through improved access to safe and sufficient blood and blood products in Kenya. Now, Dennis, imagine when schools are closed as it is right now. Deliveries do not stop, and blood donations usually decline. Facilities will occasionally face shortages of blood and blood products or blood blocks or reagents. From your experience, what are the practical advice you could give facilities and counties to ensure sustainable availability of blood and blood products for women who experience postpartum bleeding? Karibu sana, Dennis.
Thank you very much, Dr. Mitei, and all the panelists and attendees to this deliberation. First and foremost, I have to say that blood is very essential, and we have to plan for its availability, and its availability encompasses a lot of things. For instance, we also have to monitor how it is used daily. We need to have strategies in place to maintain adequate stock for blood. We also apply appropriate blood products selection during a postpartum hemorrhage. And we also need to practice patient blood management principles. And finally, to recognize the importance of rational blood use. Next slide. So on the strategies for maintaining adequate blood stocks, it's important to ensure that there will be no blood without the donor. So we have to strengthen the voluntary and remunerated blood donation. And by so doing, we're also able to ensure that we maintain and we have donor retention. We have strategic partners who help us in collecting and recruitment and mobilization for blood in our schools, in the universities, corporate institutions, uniform officers, and even the community organizations. Then we also demand reforecasting and inventory management, where we use historical consumption data to forecast demand for blood. And we also monitor stock level daily and redistribute blood between facilities and observe fast expiring, fast out. We are also able to do component therapy, which also maximizes the benefit of each donation by treating multiple patients. So we always say 1 unit of blood can save up to 3 patients. Then on public awareness education, Remember, we are also having a lot of misconceptions around blood donation. So we need to do a lot of donor awareness to ensure that Kenyans and the general public knows that blood is important to be donated to so that it can be available. Then on quality and safety assurance, we also ensure that only the safest blood can find itself in a patient's vein. So there are processes that we have to acknowledge that have to take place, ensuring the safety of the blood. Then in our hospitals, we also have to have hospital blood utilization programs. That is, for example, patient blood management systems. We also have the appropriate use of blood and blood products and immunovigilance. That is where we are emphasizing on all transfusing facilities to have a hospital transfusion committee. So on patient blood management, that is, patient blood management is equivalent to prevention plus appropriate transfusion plus better maternal outcome. And I've divided this one into three, where we are talking about prevention before delivery. There we are able to detect anemia during antenatal visits. Then we are able to prepare for and treat for the anemia. So it's important to know the probable cause for the anemia. Then we optimize the hemoglobin level. Then at the response point, that is where during the delivery, where we have PPH, we are able to rapidly diagnose PPH, and then we have early blood requisition from our clinical side. Then we emphasize on appropriate component use requisition. Then at the recovery, that is now after delivery, that is where we monitor the response, and then we rationally use transfusion. And of course, we document and audit the blood use, especially for the high-risk mothers. Next slide, please. So it is important. Next slide. The previous slide, please. Okay, now we have to optimize blood product utilization, and here the principles for appropriate transfusion run from transfusion based on clinical assessment and not just hemoglobin level alone. So we also need to emphasize on choosing the correct blood component, and we have various components for blood. We have blood packed red cells, we have fresh frozen plasma, platelets concentrate, we have cryoprecipitate, we have apheretic platelets that we are also able to request for. And then when you are requesting for blood, the requisition should come early enough so that it can ensure timely availability. Then we also emphasize on use restrictive transfusion strategies where appropriate. Then we also ensure timely communication between clinicians and the blood banks. So our takeaway home on optimization of blood here is that the safest blood is the blood the patient does not need. But when transfusion is necessary, the right blood component should reach the right patient at the right time. Next slide, please. So, and as I said, that for blood to be there, it has to be donated, and you have just to go through how the blood supply chain goes. So before anything else, we have to go the donor journey. We have to have altruism and donor awareness. So we go out there and sensitize the public about donation of blood, and that is when they can come in and really donate their blood, whether as family replacement donors or even as voluntary and remunerated donors. Then at that donation point, we also do donor care and retention, where we ensure that all the donors that come in, their first experience is as good as possible so that they can come back and donate blood again. Then we also emphasize on repeat voluntary donation, where we are able to have our first-time donors and we call them back and we're able to retain them back as blood donors. And when during this blood donation, when we collect this blood, it has to go through laboratory testing to ensure its safety and quality assurance. Then at that point, we also do blood component preparation, where we ensure that the patient can get the right product that is required. And also we have to make sure that we store the blood and distribute it appropriately so that it doesn't the blood is very perishable, so we have to ensure that the right cold chain is maintained. Then at that point is where now we have the clinical requisition for grouping and cross match, where it goes to our labs and we carry out the cross match, and that is when we can issue out the safe blood. So you can see how long the process is to ensure blood is available for our patient. Next slide, please. So our way forward here is we should emphasize on restrictive transfusion strategies. We recommend that for hemodynamic stable patients with the absence of ongoing bleeding. We also emphasize on clinical factors and laboratory parameters must align. So a decision to transfuse should not be based on clinical judgment alone. No, should be based on clinical judgment and not hemoglobin level alone. So we should also consider symptoms and hemodynamic stable patients. We should consider if the patient has an ongoing bleeding or other comorbidities. So when you're talking about transfusion options, we also should emphasize that the product selection and timely requisition is emphasized. Then on patient blood management, we should now be able to categorize our blood transfusion requisition as either elective, urgent, or desperate case, and that will also help us in terms of adopting measures like preoperative optimization of hemoglobin, where preoperative blood preparation, we have preoperative autologous donation, especially for the level 4, 5, and 6 that have capacity to do that. Then we have acute normovolemic hemodilution, and finally the postoperative management. Next slide, please. Next slide. So it is also important that during the blood, next slide, please. Next slide. So it's important to note that during blood transfusion, we also have to observe the transfusion process, and it is called the blood monitoring chart. And on my left is the blood monitoring chart where we have details of the blood transfusion processes and where the transfusion, when the time it started, we have to monitor the vitals and ensure that the transfusion is really safe. And in case we monitor any signs and symptoms of a transfusion reaction, we are able to alarm them quickly and take necessary action. On my right is a blood requisition form, which is very essential for the clinical team. When they are requesting for timely blood, they are supposed to use this form. And in this form, it also specifies the initials of the patient. We also need to know the time that the this transfusion is being requested for and by who. And for this particular reason, we also need to know which products is being requested. And the most important thing is the reason for transfusion. And also the product being requested for. And if the urgency of the transfusion, is it desperate, is it urgent, is it elective? And also it is important to have the consent for the patient. As we know very well, there are patients because of their religious beliefs, there are those who would refuse a blood transfusion to take place. So next slide, please. So I want to give us a famous quote from one of my colleagues, who is the county blood transfusion coordinator from Kiambu, who says, "We can drain both Keramenu and Ndakaini dams into 500 millimeter soda bottle if it is leaking. If it may take long, but as long as the bottle is leaking, the dam will eventually run dry. Similarly, I can give doctors and nurses all the blood that we have in our county satellites and our regional blood banks. But as long as they do not arrest the bleeding, the woman in front of them will most likely die. So let us be quick to stop PPH even as we transfuse." Next slide, please. So in conclusion, we say that the focus is not on transfusion itself, but on rapid control of bleeding, correction of coagulopathy, restoration of circulating volume, and prevention of maternal death. So blood transfusion is a life-saving bridge, not the destination. If it provides temporary support by restoring oxygen carrying capacity and maintaining circulation, while definitive measures are undertaken to control the source of bleeding, whether through urotonic drugs, oral uterine balloon tamponates, tranexamic acid, surgical intervention, interventional radiology, and hysterectomy when necessary. So the message here is simple. Transfusion keeps the mother alive long enough to achieve definitive hemorrhage control. Next slide, please. Thank you, and that is my presentation. Good evening.
Thank you very much, Dennis. I think we are all guilty of always rushing to ask for blood, other than, like you've clearly said from your colleague, if we drain the whole river, in the example that she gave of a dam, so we need to actually do something before asking for blood. I think we always just call the lab, we want blood, while we should actually be closing the tap before we call out for blood. Now, if we have all this that we've described from the clinicians, including from Dennis, and we do not have strong leadership. We do not have a system that backs us up. Are we really going to head anywhere? So allow me to invite Ms. Jedida Mirigu. She's a health administrative officer from Murang'a County. Jedida, having walked through the journey of postpartum bleeding from different levels of care, from an administrative perspective, what role do health managers and administrators play in ensuring facilities are prepared to manage postpartum bleeding? Kindly share your thoughts on staffing, commodities, emergency preparedness, financing, governance, and accountability in strengthening maternal healthcare system. Karibu sana, Jedida.
Thank you very much. Good evening, everyone. Please call me Jedida, Health Administrative Officer from Murang'a County. Now, when you talk about PPH, we are talking about an emergency there. What is involved in an emergency is providing equipment, commodities, and all the essential that are required promptly and at the right time before we fail in whatever we are managing and all that. So now, away from the daily routine, management of PPH case to an administrator requires hands-on. And when I talk about hands-on, it's not only hands-on, even the mind antennae are supposed to be up. Let's take a referral case from maybe a lower level, maybe from level 4 to level 5. First action is to instruct the security officer in charge to alert the gatekeepers of the arriving ambulance. As you can see, that ambulance is supposed to be a well-equipped ambulance, rightly filled and all that with fuel and with no mechanical problems. An ambulance, while observing and listening to the siren and the speed of the ambulance, it tells a lot. The speed of the ambulance and the siren, when the siren is on, it tells a lot about the person, the patient who is inside there. I also alert the public health officer to ensure the path to the theater is safe, clean, free, and from traffic or obstruction and all that. My instruction to the soldier and the staff wheeling the patient is to control any crowd. The stretcher used, as you can see, the one which is there, should not be producing any noise and all that. It should be a good, firm stretcher to wheel the patient in the theater. Next slide. Good. You can see now this is a theater. Look at that theater. It is well aerated. Lights with full lights. Lights are on with all the equipment which are supposed to be functional. My office calls the maintenance officer, immediate maintenance officer, to check the oxygen saturating levels, which are supposed to be maintained at 95%. And in this case, when I'm talking about oxygen, I would recommend liquid oxygen, because when the lights all goes off, the liquid oxygen will not fail you. Because if you don't have liquid oxygen, you'll now be able to deal. You'll be forced to deal with liquid cylinder, which is so the cylinders with liquid, with oxygen, and the flow meters and the pipe range might fail you at that particular time. So we need to have liquid, which is oxygen, which is really flowing, free from any obstruction and all that. Okay, the theater should be well aerated, lighting with all equipment functional. As an admin, I instruct the support staff, because when the surgery is going on, there should be a support staff just next to the theater. I'm supposed to instruct the support staff to be ready in assisting and complying on any assignment or any instructions given by the scrubbing nurse inside the theater. Next role is to quickly alert the telephone exchange person on duty to provide communication backup as need arises. As the other presenters were talking, they at one point they were calling for adding reinforcement efforts, calling the gynecologist, other teams to come and for backup and all that. Who will call those people and all that? That's the reason as to why I should have somebody close to the theater with a phone. I ensure the lab, okay, when you talk about now blood products and commodity, I ensure the lab blood satellite departments are ready with all the blood products, well secured, stored under required controlled temperatures, and ready for transfusing if need arises. I also liaise with the pharmacist. We both ensure drug shelves are all at and all the vital drugs, e.g. oxytocin, carbetoxin. I've really learned a lot about the commodities and all that, and any other drug as need arises. In both departments, that is the lab and the pharmacist, we're supposed to have at least one person who is very ready in case of any an abrupt request is made from the theater, and any question that can arise of any commodity or something which is maybe are not at the right, at the right quantity and all that. Okay, next slide. Next slide, kindly. Good. Managing close relatives. When as the ambulance was coming, there could have been maybe a husband, a sister, maybe a sister-in-law, maybe a mother to the patient who had PPH and all that, or rather who is supposed to have been managed with PPH. So as the patient is being managed, I ensure smooth communication and together with the nursing in charge, keep the med soup updated. Remember, the nursing in charge is a medic. Jedida is a non-medic and all that. As I take care of the non-medical functions, the nursing in charge is also monitoring, and together we keep the med soup updated. After all, the three of us work together very closely. Now, as a GRM focal person, okay, that is grievance redress mechanism focal person. I imagine I have relatives who followed the ambulance closely and arrived even on time. So now these people, they could be emotional. They may be wondering what is going on and all that. So as a GRM focal person, I control the relatives in case they become emotional, and I advise them the importance of staying calm, cool, and calculated, and to some extent, donate more blood instead of maybe being anxious and all that. At the end of the day, when the case of PPH is well executed, empowerment from hospital managers to the entire staff counts more. Thereafter, if not the same day, it is necessary to have case audits. Necessary so that at least we can learn and all that. And let me say this to everyone who is listening. When you're saving a mother who is giving birth to a baby bouncing boy or baby bouncing girl, in your home lineage, you could be saving an in-law in your third or fourth home lineage. So let's all cooperate and ensure things are done well. So let me thank all the doctors and all the medics who ensure that mothers go home safely when they come to deliver healthy babies. And also let me also appreciate the non-medics who ensure that we support the systems and structures of the facilities when they are conducting very expensive surgeries. Thank you so much.
Thank you very much, Jedida. Listening to you, I envy the people who work in Muranga. Imagine a system, a leadership that supports you, and eventually, even as you appreciated all of us, even though we don't directly work under you, it feels so good to wake up every morning and go to work when you know there's a system, there's a leadership that backs you up and stands by you as you serve the clients. So allow me to thank each and every one of us who's been able to join today. Thank you to our panelists. Thank you to our keynote speaker for being very, very active, even on the chats as well. I am very grateful. There's a great team behind the scenes that has been responding to your Q&A. And as we come to the close, if you have any questions, kindly still post them on the chat box. We will respond. There's a team that is responding to that. And allow me to welcome, first of all, to thank Kenyatta National Hospital, again, University of Nairobi, and the Ministry of Health. And to formally close today's session, it is my pleasure to invite Dr. Lois Nyanjau again for the closing remarks. Karibu sana, Lois, and thank you again very much. Asanteni sana, 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 sana.
Thank you so much, Dr. Mitei and all the panelists. I think it has been an amazing webinar. We have learned so much, and Jedida, kudos to you for supporting the teams. Sometimes as providers, we don't see the behind the scenes efforts, and we really appreciate you and other health administration officers for all the support that they bring. We have learned so much today, and I'd like to just summarize some of the takeaways that we can, take back to our facilities and to our colleagues. For one, I think in the first presentation, we heard that it's good to be prepared. Identify all the instruments that you need, all the commodities that you need, the medications that you need. Ensure that you have them together, prepared, just in case you get that client who comes in and may need that emergency care. You will not have time to constitute when the mother is bleeding right there before you. Secondly, please use the blood monitoring chart, because that is the one thing that will help you gauge how fast or how profuse is this bleeding and how much time do you have before the client decompensates. That chart you will use every 15 minutes for the first 2 hours, and then every 30 minutes for the next 4 hours. That is what will help you check whether is our mother okay, or do we need to start calling for help and applying the first response bundle. Additionally, we said measure the blood, use the drapes, try not to estimate. The same way we tell our colleagues, usipime joto na kuguza clients, just use that thermometer, is the same idea here. Please measure it objectively. It will help you make that decision as early as possible. Then when in the event you have a client with PPH, please institute the emotive bundle in full, all at once. Don't do sequentially, because that will lose precious time. So if it's emotive, you go at it once and for all in. Fourth, tranexamic acid is your friend. It's a first line. It's among the first line medications. So please use it within the first 3 hours of birth. It doesn't matter which level. You can now order tranexamic acid from level 2 onwards up to level 6. Then if a mother arrives stable, always have in the back of your mind that she can easily decompensate depending on the condition. And if we don't intervene early, we can die. So you can find a mother who walked in to deliver, but in a few hours, you are having a client you're resuscitating. So let's always have that in mind. And then lastly, but not least, review every case and not every death. If we put our energies and our attention to the client as and when they're before us, then we'll avert a death and avoid having an MPDSR meeting. So thank you very much. And I hope that the lessons I have learned, you have also learned. Please share with them. Help us to, at least tomorrow and maybe the next week, please teach your colleagues who are not in this webinar a thing or two that you've picked here. And then join me in thanking our moderator, Dr. Mite. She has been amazing. Please show her some love with emojis or the react buttons. Thank you so much, Dr. Mite. It has been really interesting, and I hope that we will have you again as a moderator. You're amazing. And to our panelists as well, thank you so much. Let's also show them some love. And we hope that we'll run into each other. If you see me in your county or in your facility, nisalimie and remind me where we have interacted. Hata kama ni kwa webinar, it's still a very good forum for us to exchange ideas. So thanks again, and have a good evening. And we look forward to seeing you in the next one. Back to you, Chair.
Thank you so much, Dr. Nyanjao. I like that you actually told people to see you and say hi to you. I've never met somebody with such high, sitting in a high chair, but very welcoming and very receptive to greetings and very humble. Thank you so much, Nyanjao, for always reaching out, for always giving us such platforms, for even giving us sessions for EMOC, for us to train and for us to learn as students. It's been a great pleasure for the times that we have worked with you, and we know we shall continue working with you. Dear listeners, dear participants, we are still going to hold on for about 10 minutes or 5 minutes to be able to answer some of the questions. Do not feel like we have ignored you. We are going to take our time as the team behind the scenes to just take 5 minutes to answer your questions as fast as we can. The presentations have been loaded by Nelson. Thank you so much. You can download that and look out on the KNH YouTube channel to actually watch the video, as it will be uploaded as soon as possible. Again, thank you very much. Have a lovely evening. God bless you all.
All right. One more thing, for the month of August, we will be running this series, and the next topic will be tackling anemia in pregnancy.
Thank you, Dr. Kanyi. We will definitely be on the lookout for that.